November's Bariatric Happy Hour. I'm your host, Shariff, and joining me today is my awesome co-host, Dr. Juyeon Park. For those of you joining us for the first time, these webinars are held monthly on the fourth Thursday of each month, except in November and December. So in this month and next month, it's going to be on the third Thursday of the month. And during these sessions, we review some seminal papers that have significantly influenced our field and alternate these with discussions on technical aspects of metabolic surgery. And in addition to these webinars, the Bariatric Surgery Training Committee also hosts a monthly Fellows Hours covering key topics from your core curriculum. These sessions count towards your didactic requirement needed to obtain the ASMBS Fellowship Completion Certificate. So now it's my absolute pleasure to introduce our esteemed guest, Dr. Salvatore Docimo, a highly accomplished and innovative leader in the field of gastrointestinal and metabolic surgery. Dr. Docimo is a fellowship-trained, board-certified general surgeon who brings his expertise to USF Health as an associate professor of surgery. He specializes in bariatric surgery, complex abdominal wall reconstructions, and advanced and therapeutic endoscopy. Dr. Docimo's journey in medicine began with his Doctor of Osteopathic Medicine degree from New York College of Osteopathic Medicine, followed by a surgical residency at NYU and a fellowship in minimally invasive surgery at Penn State Hershey. With over 100 peer-reviewed articles. I actually did a PubMed search. There are far more than that. Multiple book chapters and 3 textbooks to his credit. Dr. Docimo is a renowned researcher, educator, and a leader in this field. He also serves as a co-chair for the ASMBS Flexible Endoscopy Committee and holds leadership roles in several surgical societies. His work embodies a true dedication to advancing the field of surgery and improving outcomes for patients around the world. Dr. Docimo, it's a privilege to have you here with us today.
My goodness, thank you. You're make my mom proud.
You deserve every one bit of it. Now I'm going to pass on to Dr. Juyeon Park to introduce our next speaker for us.
All right, so our fellow speaker today is Dr. Jose Covarrubias. He did his bachelor's degree at UC San Diego, and he got it in biology. He did a master's additionally at Drexel University for medical science, and then he went to medical school at UC Irvine, residency at UC San Francisco, and now he is doing his fellowship at ALSA Fresno Heart and Surgical Hospital in Fresno, California. So he is coming from California, basically.
That's right.
I completely forgot that we had PowerPoint slides on this, but hey, there we had it prepared.
All right, Dr. Covarrubias, go ahead. You can share.
All right.
Stop sharing and you can start sharing now.
All right. Well, thank you for that lovely introduction. And thank you for having me today. So I have been tasked with discussing and giving a broad overview of the technical aspects of biliary access in bariatric patients, which is truly a large and perhaps daunting topic to tackle head on. But luckily for me, I found this very nice review on this very topic. So I got some very good guidelines from Dr. Docimo and as well as from ASMBS. So as we know, there are several bariatric surgeries which alter the proximal GI anatomy. In fact, with the exception of the sleeve and the lap band, I'd say just about every option available alters the anatomy in a way that renders access to the biliary tree challenging. And so hopefully after bariatric surgery, our patients will live a long and meaningful life, but throughout their lifespan, ERCP or other endoscopic procedures might be needed. And so the major challenge becomes the length of the small bowel that needs to be traversed in order to reach the ampulla. And so to address this issue, various techniques have been developed, and they can be broadly categorized into these 7 different categories. The first one of which is called device-assisted enteroscopy, or DAE. It's also known as deep endoscopy, and it's a technique that allows for deep insertion of an endoscope into the small bowel for mucosal evaluation. And through this technique, the endoscope is able to traverse the roux limb, pass into the JJ, and then reach the BP limb, where then you can go on to find the ampulla. DAE itself is an umbrella term and refers to one of three different techniques. The first one being double balloon enteroscopy, and it consists of an endoscope that has a working length of about 200 centimeters with a flexible overtube, and affixed to the end of the endoscope are two latex balloons, one attached to the end of the scope and the second attached to the overtube. And so through a series of timed inflation and deflation of these balloons, the scope is able to advance through the small bowel, and the process is repeated as necessary until the target anatomy is reached. A similar technique is single balloon enteroscopy, which involves just one balloon that is located at the tip of the overtube. And similarly, it also has a 200 centimeter endoscope. And so again, with a series of timed inflation and deflation of the overtube balloon, with the tip of the endoscope as the anchor, you're able to traverse the small bowel and repeat the process as necessary until the target anatomy is reached. And then the last of the three techniques is spiral enteroscopy, which is motorized, and it has a rotating overtube that has a spiral that can engage the bowel, and it converts the rotational energy of the spiral into a linear force that pulls the intestine onto the endoscope. So as the overtube rotates, it pleats the small bowel onto the overtube and allows for the advancement of the endoscope. And so again, this can be repeated as much as necessary until the target anatomy is reached. So these techniques have all been studied in the literature, and they are all a viable means of obtaining access to the biliary tree. So I will note that this has a relatively lower success rate, with the rate of reaching the ampulla at about 80%, and with the success of the subsequent ERCP at about 70%. And I think a lot of this has to do with the fact that ERCP is a lot more challenging via these deep endoscopes, particularly due to the need to cannulate the major papilla from a caudal approach, as well as the fact that the accessories that fit the traditional ERCP are incompatible with these long length scopes. And then that's compounded by the fact that the success rate and the potential for morbidity is also dependent on the expertise of the operator. But with that being said, it does offer the advantage of avoiding surgical intervention and offers both diagnostic and therapeutic capabilities. The next technique is lap-assisted or transgastric ERCP, which is perhaps the most common approach for access to the biliary tree in patients with surgically altered anatomy, definitely the one that I'm most familiar with. And this involves laparoscopic identification of the gastric remnant, followed by an anterior gastrotomy, and then placement of a 15 millimeter port through the gastrotomy. The port is then held in place with a purse string suture or with anchoring transfascial sutures. And then the ERCP can be performed through the port. You just have to keep in mind that you do have to place a clamping, you have to clamp the bowel on the BP limb or perform the ERCP with CO2 instead of air to minimize the bowel distension. But then once you're done with the ERCP, you close the gastrotomy either in hand-sewn fashion or with stapling. And then you also have the option of leaving a G-tube if indicated to permit easier access to the biliary tree in the future. So I think this is definitely the tried and true approach. It has a high degree of effectiveness, and the technical and clinical success is nearing 100% in the literature. And so aside from the high success rate, it has other advantages. It can be performed at the time of cholecystectomy, and in the cases of concomitant cholecystectomy, you also have the option of passing a guide wire through the cystic duct for a rendezvous technique. And then it also has the advantage of permitting the use of the standard side viewing scope for the ERCP, as well as allowing you to examine the gastric bypass anatomy and identifying and repairing any incidental internal hernias or mesenteric defects. And like I mentioned, you can also leave a G-tube for easier access to the biliary tree if you anticipate that in the future. Some of the disadvantages are that you do have to coordinate the schedule between the surgeon and the endoscopic team, which sometimes can pose logistical challenges. And in the literature, this does have a relatively higher morbidity rate, which I think is due to the fact that you have to consider both the surgical complication as well as the ERCP specific complications. Another technique is one that involves G-tube, as a primary route of access to the biliary tree. And this can be done by either placing the G-tube laparoscopically, open, or even endoscopically. And typically the G-tube is then left in place to mature anywhere from 5 to 14 days. And then afterwards, the G-tube is removed and the gastrocutaneous tract is then dilated, and which then allows you to perform your ERCP. So in essence, this is a two-stage procedure. However, there is a variation in which this can be done in a single stage, in which after you create your gastrotomy, you place a gastrocutaneous stent, and then you can perform your ERCP through the stent. And then at the completion of your ERCP, you can remove the stent and then leave a G-tube in place. So I do want to focus on the endoscopic placement of G-tubes because there's different ways of achieving this. First way is with a balloon endoscope. And so using either a double balloon or a single balloon endoscope, the gastric remnant can be accessed, which then permits placement of a percutaneous G-tube. And then ERCP can be completed either in 2 stages after the tract has matured, or as a single stage by placing a stent across the gastrotomy in the fashion that I described earlier. Another technique is through the use of endoscopic ultrasound, which involves placing an endoscope and then using the endoscopic ultrasound either from the gastric pouch or the root limb, and then accessing the gastric remnant with a 19-gauge needle under endoscopic ultrasound guidance, and then insufflating the remnant. At that point, a G-tube can be placed percutaneously into the remnant, and then you can again either complete the ERCP in 2 stages or in a single stage with the stent across the gastrotomy. There's a variation on the EUS guided technique called EDGE. And this is a technique in which the endoscope is again advanced into the gastric pouch or the root limb, and the gastric remnant is again accessed using a 19-gauge needle. You distend the gastric remnant and then pass a guide wire through the needle. The tract is dilated, and then you can place a stent either from the pouch to the remnant or from the root to the remnant. And then once you have your stent placed, then you can either perform your ERCP at that session or in a later session once the tract has matured. But then after you complete your ERCP, you can remove the stent, and then the fistula that was created is then closed using a variety of different techniques, which can include endoscopic suturing with clips, with ablation of the fistula tract, or by placement of a double pigtail stent to facilitate the closure of that fistula. I do have to say that this is still considered an investigational technique, but it does have the advantage of allowing you to use the standard side viewing scope for your ERCP. And again, this would obviate the need of a surgical intervention. And it has been used for both urgent and non-urgent clinical indications. And in the literature thus far, the clinical success rate of this procedure is very high at about 95%. It does have some disadvantages, and a lot of those have to do with the concern of creating a persistent gastrogastric or gastrojejunal fistula. And so the potential for a chronic fistula is of concern. But so far, the short-term data suggests that this is a technique that is successful and with successful closure of the fistula, at least in the short term. However, given that it's still considered an investigational technique, I think this would really only be performed in an IRB setting. Another technique is biliary access through a transenteric approach. And in this technique, access is typically attained through the proximal jejunum by creating a jejunostomy with a purse string suture around it. The jejunostomy is then brought up to the abdominal wall, and a laparoscopic port is placed through the jejunostomy. Purse string suture is then secured around the port, and then you can perform your ERCP through the port in a similar fashion as you would for your transgastric approach, but again, the access is through the jejunum. And I would say that this is probably the technique of choice for patients with a duodenal switch. And in cases of choledocholitis, there's also, of course, the possibility of a common bile duct exploration. So if performed at the time of cholecystectomy, this can be done via a transcystic approach, but you can also achieve this through a transductal approach in which a choledochotomy is made at the CVD, and then you insert your choledocoscope, identify your stones. Then after you extract the stones, you close the choledochotomy, typically with an absorbable suture. And if performed by an experienced surgeon, this technique has a high success rate at about 90% and would obviate the need of any postoperative procedures to relieve any biliary obstructions. But in my opinion, I think that the downside is that there's perhaps a progressive loss in the technical know-how in terms of how to perform this procedure, at least in younger surgeons like myself. I know in residency, I saw a handful of these, but I certainly wouldn't say I'm comfortable performing this myself. Then the final technique I want to talk about is the transbiliary axis of the ampulla, which can be achieved through a percutaneous transhepatic approach or an endoscopic ultrasound approach. And so on the left, I have a picture of percutaneous transhepatic cholangiography, which is an interventional radiology technique. And it's indicated in patients with surgically altered anatomy and is considered second line after either a failed ERCP or when the endoscopist isn't available. It is effective and it provides expeditious access and decompression of the biliary tree through placement of a transhepatic catheter, and can be used also to perform dilation of the ampulla and for stone removal. However, I will say that the success of this depends largely on whether there is dilation in the biliary tree. And so when the ducts are dilated, the success rate can be as high as 95%. But when there is no dilation, the success rate is maybe about 70%. It's also not something that would be able to be done in someone who has active coagulopathy. The other approach that I want to talk about, which is depicted on the right, is access to the biliary tree that can be obtained under endoscopic ultrasound guidance. So in this technique, a fine needle is used to puncture an intrahepatic duct using endoscopic ultrasound from the gastric pouch, and which then a guide wire is advanced through the ducts and across the ampulla, and then about a 5.5 French ERCP cannula is then used to dilate the now transhepatic and transgastric tract. And then typically a stent is placed across this tract. And then now you can perform at that point your balloon sphincterotomy and extraction of your stones. This is really considered more an alternative to the traditional PTBD. So most of the studies available on this topic are more comparative studies between that technique and the PTBD. And so far, it has been shown to have a higher success rate with fewer adverse events relative to the PTBD, and would also have the benefit of not requiring external drainage with the catheter. However, it is noted that there is a steep learning curve and is only really performed by the most experienced endoscopists. And it's also a highly specialized procedure and not widely available. So you probably would only find it either in an academic setting or in highly specialized centers. So that's my overview.
Thank you. That was a very comprehensive overview. So now, Dr. Docimo, if you want to show us how it's actually done, we'd love that.
Jose, that was fantastic, though. Honestly, really good review. I think it's important. Obviously, I have some of these same slides actually in mind because I think they're really important topics. But it's really important to understand, even if you don't do any of this stuff, right? Just that when a patient comes to your door, comes to the emergency room, having the ability to have a conversation with them, having the ability to understand what you need to do for them is obviously, it's key. It's important because a lot of times when these patients come in, they come in an acute setting. They're kind of in dire straits, so you really don't want to be wasting too much time with them. So, all right, so we're going to kind of talk about a topic that I honestly just really enjoyed doing. I think these are really fun cases. Part of that is the fact that we did a lot of I did a lot of advanced endoscopy. Kind of cannulating and dealing with the common bile duct is, I think, a lot of times is almost It's kind of like forbidden fruit for surgical residents for some reason. We're always told not to go near it. You want to stay away from it. You're always a little bit afraid of it. And I think that's kind of the wrong thing, right? We don't want to give that impression off that this is anatomy that, we basically can't hold, or we can't deal with anymore. So these are my disclosures. Just full disclosure here, Boston Scientific. So I do receive some, I do some teaching and training for them as well. So some of this devices you'll see in this lecture, but hopefully you don't think I'm too biased. All right. So, basic stuff, right? So what are we really talking about? We're talking about stones really can form anywhere in the biliary tract, from the gallbladder, hepatics, down to obviously the common bile duct. Most commonly, we're going to see stones that are going to be present in the common bile duct, and that's really what we're going to be focusing on. It's important in the world of bariatrics, especially nowadays, in terms of all this new procedures coming, SADI, duodenal switch, one anastomosis, all this stuff that's really even going on in Europe, South America, because a lot of these patients are coming to the US. So you really want to understand, what is being done from an anatomical perspective. And then that's really going to allow you to really understand, how do I access, the biliary system when these patients come in? Because, years ago, obviously, if we all remember, we used to take out the gallbladders for every patient that came in for primarily really a bypass or switch, or they would always get their gallbladder taken out. We kind of gotten away from that, probably for the right reasons. But we still see a lot of formation of common bile duct stones after bariatric surgery, right? We do know that increased weight loss, there is some association with with biliary stone formation. So we see that. And these patients do come in, and they obviously they present a really unique challenge, because we can't get down to can't get down to the sphincter going through the stomach and the duodenum, right? We don't have access for some of these patients. So you really want to understand all of this, and Jose just did a phenomenal job really going over a lot of this. So, and I'm glad he did, because I really want to focus on really transcystic common bile duct expiration. But these are the different variants of access to the CBD. Again, even if you're never going to do them, it's really important to know, hey, these things are out there. And when you have, when you call on someone, a gastroenterologist or another endoscopist or surgical does these procedures, or a surgeon, it's important that you can have a conversation with them, okay? So a lot of the stuff that we talked about, like, having straightforward anatomy where you go in, you do a duodenoscope and you access the common bile duct, a lot of these bariatric patients, just not going to be accessible. We kind of talked about this paper previously. All this information is on there. So again, if you really want to go back to and really kind of understand, obviously, it's all there and it's all really nicely summarized. Couple of things though. These techniques are out there though, but they're not very common. They're hard to do, they're time consuming, and they're really not commonplace, to be honest. Unless you're in a larger academic setting, it's really hard to find an individual who's committed to doing this stuff, okay? Even though it's out there. So even though we present this, as options, in the vast majority of our clinical practices, this stuff is not an option, right? So you have to understand, it's important to know that it's present, but things that are more common, right? Like transgastric ERCP, obviously a little bit more common. I think even the edge is becoming more common, and we could spend a whole hour just talking about that topic alone, but I think for the right patient in the right setting, the edge procedure is a really good option for a patient, okay? But again, whatever that, I'll leave that definition up to you and whoever's on call one night, and conversations between the endoscopist and the surgeon, et cetera, who is a good candidate for an edge, okay? But overall, as I mentioned, edge procedures, there's some issues with them. Obviously, there's some association with bleeding, perforation, et cetera. Chronic fistula formation is still a problem with an edge. So as I mentioned, good to know, good in the right situation. Is it perfect? No. Is anything in surgery or endoscopy perfect? No. But it's good to know that's out there, okay? Transenteric approaches, I think this is, Jose kind of mentioned this as well, really important to know. Why? Because when you have cases like duodenal switch, SADI, you're probably going to end up doing this. If the patient already had their gallbladder out and they come in with a CBD stone, this is probably going to be the way to go. Similar to what you would do at a transgastric, you're just going to access the small bowel and go proximal up with a duodenal scope or a forward viewing scope as well. All right, so let's hop into some of the fun stuff here too. So, transcystic common bile duct aspiration, and I know Jose kind of mentioned this, and I think this is why I'm really excited that we're doing this, simply because if you can take out a gallbladder and you can do some basic endoscopy, you have all the skills that you need to do this procedure. All right. You know, and I'm being really genuine when I say this. This is not really hard stuff. It is literally just having someone show you how to do it, and you just get comfortable doing a couple of them. I don't think you need to do 50 of these, or, you know, you got to be careful, obviously, when you're first starting out. But as a surgeon, you have all the basic skills to do this. This procedure's been around forever. There's nothing new. We're not reinventing the wheel. We're just really going back and re-educating and reteaching people how to do the procedure. Okay. So transcystic common bile duct approaches, you know, there's similar stone clearances as an ERCP, but there's a lot of advantages, right? There's, you know, shorter length of stay with a single stage. Single stage meaning that we take a patient to the OR, we do a transcystic approach, we clear out the common bile duct, take out the gallbladder, send them home. Okay, single stage approach. Shorter length of stay, less cost. If you look at some of the data, we can even probably say that there's some less complications, right? So if you look at the pancreatitis rate alone between transcystic common bile duct aspiration and ERCP, ERCP holds somewhere between 10 and 50% pancreatitis, right? That's really high. You know, even if a patient has really mild pancreatitis, it's probably going to buy them another day or two inside of the hospital. And if they have severe pancreatitis, you're talking about, you know, a good amount of stay with a significant cost. Okay, so on average, for any patient who has some elevation in their LFTs, or if they have any evidence of pancreatitis after an ERCP, probably buying them at least a minimum another 2 or 3 days in the hospital. Okay, it's a huge cost burden. So if we have a procedure that we can eliminate the vast majority of that, we got to really kind of, we really got to revisit it. And I think, you know, a lot of us are kind of currently working on that data. All right. So again, all the data is out there. This is, you know, we're not going to kind of beat a dead horse here a little bit, but shorter length of stay, right? You're going to really, if you're interested in doing this procedure in your hospital, and there's some pushback in terms of getting a scope, or there's cost, et cetera, you have all the data that's been published and out there. You can clearly show them that, hey, listen, you know, and think about a scenario like this, right? Patient comes in on a Friday, early Friday morning or late Thursday night, and they have CVD stones. Vast majority of what's going to happen, they're going to get GI consult. They're probably going to get an MRCP, which doesn't happen over the weekend. Maybe they're going to get their ERCP on a Monday, maybe operate on them on a Tuesday, and they're probably going to go home on a Wednesday. Okay, so that's Friday, Saturday, Sunday, Monday, Tuesday, Wednesday. It's 6 days, right? Now, if you get that same consult and you do transcystic common bile duct aspiration, get that call late Thursday night, put them on the schedule for Friday, clear out their CBD, take out their gallbladder, send them home. They're home in a day. Okay, so it's quite obvious that, you know, we probably have a little bit of an issue here that we probably have to readdress. You know, and again, it's all comes down to, you know, keeping these beds open for other patients, you know, providing value to our patient, providing value to our healthcare system, you know, and again, it all goes back to reteaching residents and attendings how to do these cases. Okay. All right. So how do we do this case? All right. First and foremost, preparation. All right. So I have a cart that I have everything on there. I have my scopes, I have wires, I have balloon dilators, I have contrast, I have kind of everything I need. I even have extra cords if I got to kind of like, you know, bring some auxiliary monitors. I mean, everything I need is on there. Okay. The device that I use is a disposable common bile duct scope. It's a plug and play. I simply plug it in, I use it, and it goes in the trash. Okay. So why do we do that? The reason why, again, it's really simple to use, which I love, right? So if I'm doing these cases, which a lot of these cases come in, you know, overnight, they're acute cases, you know, I don't have to really worry about people kind of getting everything organized. I can simply bring in the cart, plug it in, I can use it, and that's it. The visualization is excellent. I don't have to worry about the scope being reprocessed. I don't have to do any of that. I can simply really kind of move forward with the case. Okay. So what's the algorithm, what's the algorithm that we're going to use? So this algorithm here, again, is for newer cases that are newer, are individuals who want to just first start doing these procedures, okay? And a couple of things that we have to look at is stone location. That's number one. So most of the time, if you're first starting to do these cases, only go for CBD stones. Okay. Number two is stone size. So we always say kind of when you're first starting out, look for smaller stones. It makes sense, right? Smaller stones are going to be easier to get, to grab. They're going to be easier to pull out of the cystic duct. It makes sense. Why is it 6 millimeters? That really comes up to the fact of how comfortable you're going to be dilating initially the cystic duct. So we'll go over that in a minute. Number of stones, you want to be less than 5. Cystic duct size, you want it to be greater than 4 millimeters or so. Obviously, the bigger the cystic duct, the better off you're going to be because it's going to be easier to get the scope in, easier to take the stones out. Cystic duct insertion, this is just understanding that there's aberrant anatomy, right? We all kind of know this. I'm not going to lie, I've never really had an issue with a really oddly placed cystic duct that I couldn't get a scope in. So when you take all this information in this algorithm and in your mind, you quickly go through this, if you're like, listen, my patient fits all this criteria, go for it, right? Try to do a transcystic common bile duct aspiration. If you bring someone to the OR and you're like, hey, I'm not, I got a really small cystic duct, I got a really big stone, I did my cholangiogram, this thing looks really big, I can't get the stone out. It's fine, just take out the gallbladder and then, send them for an ERCP. If you feel comfortable doing a true common bile duct aspiration, you can also do that, but I think that's a whole nother lecture. All right. So it's really no harm, no foul, right? You get in there, if you're like, listen, I tried to do it, I can't do it, just take out the gallbladder, send them for an ERCP. If I get in that scenario, by the way, I don't leave drains. You're not going to blow out the cystic duct with an ERCP. It's not going to happen. The only thing I do differently, though, because I'm like every other human being and I want to sleep well at night, I put clips and then I also tie down the cystic duct as well. Okay? All right, so port placement. So it's exactly the same. And I'm going to do both. I'm going to go over lap and I'm actually going to touch on robotic as well. I put the ports in the same exact position, as you would for a lap common bile duct aspiration. The only real difference is I will still put in an extra 5 millimeter port underneath the right rib line, and that's going to be my access point for everything. We used to do different cannulas. I try to, I don't do any of that anymore. I put another 5 millimeter port, whether I'm doing this lap or robot. It is a world of a difference. I'll tell you why. If you try to utilize some of those ports that are much lower, what happens is that when you come in with the choledocoscope, you're going perpendicular to the common bile duct, okay? Or the cystic duct, I apologize. You're going perpendicular. So basically when you enter the cystic duct, you literally got to make a 90-degree turn and go all the way back down, okay? By moving another port right below the right rib line, okay? When you come in with the common bile duct scope or the choledocoscope, you're going perfectly parallel to the cystic duct. Usually it goes in and you're going to go straight down. You're going to go right into the common bile duct. And I'll show you this with a couple of videos, okay? All right. And I guess always get your critical view of safety. That's like a known standard, okay? Cholangiograms. Cholangiograms are so unbelievably important. I would try to push to do a cholangiogram on everybody. And especially if you want to learn and you want to do this procedure, do it. And there's two main reasons why. One, you're going to get your team comfortable doing something different, right? You got to get comfortable bringing in the C-arm. You got to get comfortable understanding all the anatomy, all that stuff. So you just got to get the whole team comfortable. Two, you're going to learn what is normal. If you're going to recognize what's abnormal, you got to see a ton of normal findings, okay? So the more and more and the more you do, you're going to quickly be able to evaluate the situation. You're going to read abnormalities. It's like anything else in life. You got to practice, right? So the more you do this, you're going to get better. Your team's going to get better. And the cholangiogram is going to go from a 45-minute ordeal to literally 10 minutes, okay? So a couple of things. So what you want to look for are filling defect, meniscus signs, lack of duodenal filling. Lack of duodenal filling is actually really important because I think most of the time we miss that. So everyone wants to look for a huge stone. Everyone wants to look for the textbook meniscus sign. It's not always going to be there. However, a lot of times you'll get, small particles or small stones that's layering at the bottom of the common bile duct, and it's going to be essentially sludge. When you go and shoot your contrast, the duodenum is going to fill slowly. That's going to be slow duodenal filling or even a lack of duodenal filling. That's an indication to do a cholecystoscopy, okay? So I use a straightforward 5 French catheter. I usually go do a balloon catheter tip. So, and I love it. I have a 5 French balloon catheter. It goes into the cystic duct. I inflate the balloon. I drop some contrast. I'm not gonna lie, I don't use any special clamps. I like to be really simple. Half the time I can't find the clamp. The other half of the time when it is there, it doesn't even work. So I just got away from that. Just, kind of go to your urology friends, scrounge up a 5 French balloon tip catheter, take 5 of them and hide them in a cart somewhere and you'll be fine. So that's my best advice. And then, just get a bunch of them, have your OR purchase them. They're really easy to use. Easiest way to do it, okay? Out of all the awesome videos, and obviously I love videos, this is probably the most important slide here, though, to take home. So most people get really most uncomfortable with this procedure when they have to dilate, okay? Understandably, right? If you overdilate, you're going to cause an injury. Now you went from a common bile duct stone to a common bile duct injury that you have to repair. It can get a little nerve-wracking, okay? So you got to understand what you're looking at. Again, this goes back to really understanding, hey, how do I, do more cholangiograms, right? Because you really understand what's normal, what's abnormal. But then also, you're going to have the ability to really understand the situation that you're in. So what does that mean? When you do the cholangiogram, if you take a known structure like an Olsen clamp, for example, or even some type of a D&G grasp or something, they're all going to be about 5 millimeter in size approximately. As you do more and more of these and you look at this, you're going to say, okay, I can start to understand quickly what type of anatomy that I'm dealing with, right? So if the cystic duct is the same size as the clamp, it's 5 millimeters. In this picture, the common bile duct is about double the size of the clamp. I got a probably 10 millimeter CBD or common bile duct. You see that little stone at the bottom there? It's about probably a little bit smaller than that grasper or the Olsen clamp. So it's probably about 3 to 4 millimeter stone. The cystic duct is about the same size as the clamp, so I'm probably dealing with a 4 to 5 millimeter size cystic duct, okay? As you do more and more of this, you're going to really be able to quickly evaluate what you're dealing with, and then you're like, okay, I can tackle this stone transcystically, and you're going to do it, okay? Now, dilation. All right, so I'm gonna tell you exactly what I do, and I think it's fine. I think it's a safe way to do it. Some people will kind of dilate pretty much all the time before they put a scope in. I've gotten away from that. I don't think it's necessary. What I do is I get in there. I do a cholangiogram. If there's a stone, or I know that there's a stone there, I'm gonna make a ductotomy. I'm gonna go with my choledocoscope, and I'm gonna grab the cystic duct or the gallbladder. I'm gonna push it up to the patient's right shoulder. I'm gonna try to straighten out the valves, and I'm gonna try to advance the common bile duct, the choledocoscope. If the scope goes into the common bile duct, I'm done, right? I'm ready to go. If the scope doesn't go in, that's my sign that, hey, I gotta dilate, okay? Couple rules with dilation. Never dilate the cystic duct bigger than the common bile duct. So obviously this situation here, you got 10 millimeter CBD, don't dilate the cystic duct up to 10. I would never go above 8 anyway, right? 8 millimeters, I think, is a fair cutoff for a cystic duct dilation for most cases. It's enough to get the scope in. Most importantly, you don't want to make an injury, right? That's the last thing you want to do. So once you get in there, if you're going to have to dilate, there's a couple things you could do. If you're first starting out and you're a little nervous, put a wire down. Just get a wire, feed it into the common bile duct. It's going to go all the way into the duodenum. That's going to be your guide point, your access point. At that point, you can put anything over the wire. You can put your balloon dilator. You can even put the scope over it if you need to. It's an access point. I've gotten away from that a little bit too, in all honesty. At this point, I feel pretty comfortable even just passing a balloon in and dilating the cystic duct without a wire. But that's not common. Most of the time, we'll still drop a quick wire in, get a quick shot, put a balloon in, and dilate up. And that's just really kind of the normal progression. So now, as I mentioned before, if you've done any basic endoscopy, you've probably done some basic dilations. This is it, right? So we're going to slide the balloon over the wire, simply goes in. You're going to dilate up. And most balloons on my cart are about 4 to 6 millimeters in size. Once the balloon's inflated, I usually wait about a minute or so, 60 seconds or less. It's good enough time to tell a dad joke, right? Or two.
So, sorry if I may interrupt. You don't use a you don't use a wire for these balloons nowadays?
Sometimes I don't, but I've got, it's a matter of how comfortable you get doing some of this. I would not recommend that, right? If you're starting out, put a wire in, do a cleanse, take a quick shot, make sure the wire is in the duodenum, and then just pass this over. The wire is just making sure that you're dilating across the cystic duct, and that's what you're trying to dilate. You're trying to dilate those valves across the cystic duct in order to get the scope in, okay? So I would still recommend, if you're just starting out, it's like everything else. When you get really comfortable doing things, you can be a little bit more aggressive. I would still put a wire and dilate and do, take a fluoro or a shot to be comfortable, okay? Just to be sure.
All right.
So there's your wire right there. I mean, there's your guide wire. Once your wire is in, you could try putting the scope over. You can even try, if that doesn't work, then you go straight to the balloon, then you dilate up. But 4 to 6 millimeters, like I said, the max I'll probably myself even go is 8 millimeter dilation. I won't go any higher than that. You really just run the risk of the cystic duct just shredding onto the common bile duct. So you got to be careful, because then now you got a little bit bigger problem for yourself and for the patient. All right, so these are just some picture. We're gonna go over a couple of videos here now. So this part here is important, right? So I'm gonna go back for a second. But you can see how, as the scope is going in, I'm taking the lap grasper and I'm grabbing the cystic duct and pulling up and almost to the right patient's shoulder. I'm just literally trying to straighten out the valves and give a little bit more direct shot that the scope can go in.
Now, again, are you doing this over the wire, or would you recommend us who are starting off to do this over the wire?
I think it's totally safe to try to do this without a wire. I don't think you do any harm. My current algorithm is I do my ductotomy. I get my scope. If I can get my scope into the cystic duct, I'm going to irrigate on the scope. The scope has an irrigation tube, and I usually hook it up to an Irby device. And as I'm pushing it forward, I'm stepping on the Irby, and what it's doing is it's flushing water. It's also dilating the cystic duct, and I'm going to try to advance it forward. So you have basically one person advancing the scope, and the other person is really kind of, manipulating so you can find the center of the valves, and then we could traverse into the common bile duct, okay?
Right.
If it doesn't go, I don't force it. At that point, then I put a wire down, then we do a balloon dilation, or I go straight to the dilation, yeah.
I found it like passing the scope over a wire much harder. So
yes.
I feel like personally taking the wire out and then just passing it is easier than over the wire, because I feel like the scope is a little bit stiffer than the regular scope that you use.
Yeah. Yeah, I think so. I think the easiest part with the wire is, let's say you have the wire down into the duodenum, you pass a balloon over it, you do a dilation, then passing the scope over the wire is probably a little bit easier. But because you got to remember, it doesn't, when you put the wire in, the wire is small enough and flexible enough to traverse the valves, right? So you can get a wire in easily, but those valves, if they're kind of shut, even if you have a wire there, the scope's not going to go. It's just going to bend into the valves. So even that point, you still have to dilate. Now, if you have a stone that's been in the common bile duct for a long time, and the CBD is dilated and the cystic duct is dilated, then you can just drop the scope. If it's dilated, it's going to go in no matter what.
Yeah.
So the wire, the wire is super helpful. It's a guide, like I said, it's almost your lifeline. But for the most part, it's not gonna solve the problem of undilated valves. Right. Yeah. So I got some better videos, but I just want to show you this because this is a good point here too. So now that we're in here, I'm going to keep irrigating. You can see these stones here. This is almost, the stone here is all broken up. It's just these tiny little pieces. There's no way I can even grab this with a basket. What I like about this is I can literally just take the scope and kind of gently push these all down into the common bile duct. And then I know that I'm completely clear. And we talk about this every once in a while now too, in terms of, if you take a scope and you advance it into the duodenum and you see all the duodenum mucosa there, do you still need to do a cholangiogram? And I think for stone reasons, probably not. I think the biggest reason we still recommend completion cholangiograms, you want to make sure that there's just no injury somewhere.
Right, right.
I think that's the key. So we haven't figured that out just yet. And the nice thing about, at least about this scope, is I'm throwing it in the trash afterwards when I'm done, right? So I can dump as much contrast through this scope as I want and do a completion cholangiogram through it as well. So it saves me a little bit of time. All right.
And you go all the way to the DO, right? You see the
Yeah, I like going into it. Yeah. So here's another video here. And again, this is pretty much just showing you kind of just popping through. So there's all these,
look at that.
I like going through there. I like, because sometimes when those stones are sitting distally, you're getting some sphincter contraction, you're kind of banging into it, it's spasming. I like to literally go in there and just kind of dilate this up. And there's some people that, some people even pass a wire and dilate the sphincter itself as well.
Oh, they do? Okay.
Yeah, some people do that. I don't personally do it. I don't think it's necessary. If I pass the scope, it's going to go in there. Because don't forget, the scope is like, scope is below, it's smaller than 5 millimeter too, but just under 4, it's not something to shake your head at. It's still sizable.
Right, right.
So this is another fun video here. So we're in the common bile duct, and I want to show you this is the benefit of having like that herby water jet. You can see with the water jet hooked up to this, as I'm irrigating, you can see how nicely dilated it gets. Right. Now I like the picture because it kind of looks like, wow, look how big that opening is, man. I can drive a truck through that thing, right, to get into the duodenum. The reality is that's actually an impacted stone. So what I'm going to do in this situation, because I like to get the stone loose, have it kind of rolling around. It's the easiest way to grab it. So I'm going to take a wire. I'm actually going to kind of keep pushing the wire toward the stone, almost nudging it out. The scope that I use it's like a miniature gastroscope, right? I can deflect up and down, left and right. So as long as my wires to the side of that stone are just beyond it, I'm going to try to nudge it out. Once it's out, the technique is this. You take the tip of your basket, you go just beyond the stone. You open the basket, and you're going to slowly pull back on the basket, and you're going to give a little bit of quick little jiggle, and that's usually going to capture the stone. And then what you're going to do at this point is you're going to grab the stone in the basket. You're going to pull that stone as close and as flush to the scope as you can. And you want to pull the whole thing out in one unit, okay? If you're not holding that stone against the scope, what's going to happen is you're going to pull the scope out, and now you're going to have a wire going through the cystic duct into the common bile duct with a stone on the end of it. It's like a cheese cutter, right? So if you keep playing with this thing, you're gonna slice right through it. Nothing to worry about. What you're going to do is you're going to use that wire as the guide wire. You're going to go right back into the common bile duct and then just try it again, okay? So once that's done, we're going to do our cholangiogram, and then it's just going to show you that everything looks good. You didn't make a hole somewhere, and you got your nice before and after. You want to make sure there's no filling defect, but you want to see that rapid filling of the duodenum as well. So for the last few minutes we have here, I want to chat a little bit about robotic cholecystectomy. So this is exciting because obviously it's kind of like the colliding of like these new technologies a little bit. The reason why I think it's important to talk about this too is the fact that the reason we lost this whole technique was because laparoscopy came out. Everyone was just like, how the heck am I going to take gallbladder out of these tiny little incisions? They're all hyper-focused on this like one task of doing minimally invasive surgery, taking the gallbladder out of these 4 little holes. On the flip side, ERCP is becoming easily accessible. So it was a perfect storm. So when you had the advent of laparoscopy and you had ERCP all at the same time, everyone was just like, I don't have time to think about how to do a cholangiogram. Oh, I don't have time to get the stone out. They were so focused on lap. It was a perfect storm. We lost the technique. Okay. Robotic. Now we've made really good headway in reteaching residents and attendings how to do common bile duct expiration. We've honestly, it's like everyone wants to learn this, and they should, right? Yeah. The concern I have though now is like robotic cholecystectomy now is really coming to the forefront. Right. Now that's becoming more popular. I don't want the same thing to happen because now people are like, Well, I'm doing a robotic gallbladder. How the heck am I going to bring in a C-arm?
Yeah.
You get in there and do a cholecystectomy. Forget it. I'll just send it off to GI and I'll just take out the gallbladder. It's like a vicious cycle.
But the
So
thing is, for us, that's not an option, right? Sending it to GI is not really an option if you're doing things like SADIs and DSs. So
yes, yeah,
I feel like personally, most bariatric surgeons should learn how to do these
yes.
transthoracic Italy's.
So this is why we published this, right?
Mm-hmm.
It was really just honestly, I really mean this. It's literally just saying, okay, I got this case. I'm going to just commit the time. I'm going to do it.
Right.
And you're going to struggle. But after you do 2-3 times, you're like, this is easy, right? You're
Right.
going to go from, it's going to take you an hour. People are going to swear at you. People are going to be mad. They're going to be talking underneath their breath. And then by the second, third time, you're like, wow, this took me 40 minutes. Hey, this only took me 20 minutes. And
Right.
people are going to love it, right? It's going to be actually fun for them. So similar as we did before, I use the same exact robotic port. So 1, 2, and 3, and 4, right across the umbilicus and a little bit of an angle. Again, the only difference is that 5 millimeter port right below the right rib line. That's it. Once I get that port in, I'm coming in parallel to the cystic duct. I can do my cholangiogram. I can do the the cholecystectomy through there. That's it. There's nothing magical with this. Okay. So this is just the port placements, and this is a left side dock, obviously. We come in from the left side. I got the C-arm on the right. I got the auxiliary monitor, and I got my Discover card, my choledocoscope on the patient's right side. The auxiliary monitor is where I run my choledocoscope because I would need to have a separate monitor doing that. And the way that we do this is we drop arms, 1 and 2 down to the thigh and to the right. 3 and 4 go down to the right and to the left. And at that point, the C-arm is going to be tilted probably about 30 degrees, maybe a little bit more. And it just comes right in. When you swing the arms out between 2 and 3, you have an opening that you could just do your cholangiogram. And that's it. Okay. The biggest hurdle with this is just literally remembering to make sure the bed is turned the right way so that you're not banging into the pedestal of the bed. So you make sure that the bed is correctly placed because they're already going to be in head up position, right? They're going to be in head up and berg. So,
do you have Trump beds too? Like, do you have Trump beds for the robotic cases? Like, do they sync with?
No, I mean, other people are using, they're like, you're just a bariatric surgeon. You don't get the bed, right? It has to go to and all this stuff. So no, you just gotta be mindful, like when you're starting the case, to like just check these like minor little details.
Because with the Trump bed, you need to slide all the way up so that the C-arm can slide. So I think, like you said, it's all about setting up the room. The first time you do it, it took me 3 hours. Literally, I wanted to cry. But afterwards, it goes much faster. Once you know how to set up it's like a puzzle that you need to solve. Like, where's the robot coming? Where's the C-arm coming? Where are you going to place these things?
And and like I said, the tech, the first time the tech came in, he literally walked out. He's like, I'm like, come on. And like the room that we're doing this in, in this picture here too, is small. It's not a big room. Everything fit in just fine. All the you can't see it, but the robotic consoles are actually behind toward the left of the C-arm. So we were able to get it done. And it's just like I said, once the cholangiogram is done, I just slide right in there and I put the choledocoscope in. So it depends on who's at the bedside and what they're doing. So if I'm running the choledocoscope, I have whoever's running the robot, they're going to grab the instrument and they're going to just push the scope down into it.
Yeah.
Personal experience, I've never had to dilate yet when doing one of these robotically. I don't know what it is. I don't know if I can just stretch the valves out a little bit more. I don't know if I just have a little bit better angulation with the scope, but I haven't had to dilate one yet. So I'm sure it'll happen though. It's going to happen at some point. But I
thought you had to dilate. At least that's what the rep said. So I have always dilated these.
Absolutely not.
Okay, next time.
No. No need to do that. Most of the time, all right. A lot of times with the stones, everything is dilated, right? You have an advantage there. So it's not necessary to do that for every case. It's actually more uncommon the need to dilate than it is to dilate, to be honest.
Okay.
Like I said, I put the scope in. If it doesn't go, I dilate. It's kind of a really simple algorithm. It makes sense, right?
And And what part do you do, and what part do you give your resident fellow to do?
Most of them like to do the cholecystoscopy part of it.
Yeah, for
So,
some reason.
so I have to bite the bullet and hand it over sometimes. But I like
I
doing it.
feel like with the robot, you can guide them through that. Like you can literally, they just have to push
Yeah,
through, and then you can just kind of,
I feel better. Like I feel better with them doing it if I'm if I'm doing it robotically though, because I do feel like I have control over it.
yeah,
Once,
yeah,
once they're in the common bile duct, it's like it's a wire, it's open, close, grab the stone, pull it out, right? It's not, this is basic stuff. It's just literally getting comfortable saying, hey, this is what I'm going to do, understanding your instruments and doing it, right? So you can see here, we're going to kind of keep pushing this forward. And what you can't see off screen though, is that all I'm telling them is like, hey, center me, go to the dark.
right.
Like anything else in endoscopy, you want to go to the dark. And then once I'm centered, they're gonna hit the pedal on the Irby. I'm gonna push the scope down, and then at that point, that's it. Then it's just like any other code. At this point, whoever's at the bedside has total control. It's like even with the robot, I'm just waiting for them to finish the case. So this is a great example. So I'm gonna put the tip of the basket just beyond the stone. We're gonna open the basket, and then we're gonna slowly pull this back, give it a quick little jiggle. The stone, the wire is going to open up around the stone, and then we're going to grasp it. All right. So that's it.
That's beautiful.
You got to be careful because sometimes, if the stone is further down and if you push this wire grasper or basket into the duodenum and you open up, sometimes, there's little ridges on these wires, on these baskets. You'll get stuck on the duodenum mucosa and you're like, oh man. And it's nerve wracking, but you got to just jiggle back and forth. It'll come loose.
Okay.
Now here robotically, all right, this is great. So now you can kind of see why I like doing these things robotically. So clearly I was a little aggressive. The stone is kind of big, right? We're kind of lodged now in the cystic duct. No problem. It's okay, right? So I'm gonna just take my scissor. I got articulating hands. I can just literally just cut, burn, and I can just take my time, and as soon as the stones pops out, I'm done. I don't have to keep going any further. So
Perfect.
yeah. So
Oh,
yeah, so a couple, what you could also do here if you want, you could take a lap grasper and try to crush the stone, but I have a wire in there and I'm fine. I mean, I got a lot of length on here. So once I take this, I got a lot of length to put my clips on. Important question that I didn't mention earlier. The number one, one of the most common questions that we always get is, where do I make my ductotomy?
Yeah.
Okay. And the easiest answer to this is, and you can see this is pretty sizable ductotomy now. Try to you want to go as close as you can to the common bile duct, but still leave enough room to put your clips on.
Okay.
And the reason why is if you go because when you first start doing this, everyone wants to go further away because they're nervous, right? Everyone is nervous. It's the common bile duct. Something's gonna go wrong, etc. You're scared. Totally normal. Okay, I did the same thing. So you're gonna go further away. The problem is once you go further away, now you got all these valves and ridges that you got to traverse. It's a struggle fest, right? So try to go closer. You want to go close to common bile duct, but you want to leave enough enough length between the ductotomy and the common bile duct that, hey, if I got to make it a little bit bigger or whatever, if it tears a little bit, I still got plenty of room to put a stitch or a clip. Right. So there's no magic number. I can't say just go 2 centimeters away or whatever. That is the best advice I can honestly give. And it just comes with time understanding that.
Perfect. We have a few questions on the chat. Juyeon, do you want to ask them?
Yeah, I think the most relevant question, especially for the fellows, someone was asking, how did you really get started in doing these procedures? Especially like for the people who are training, like some of us don't get experience in doing this in their fellowships or in their residency. So how can you like get involved? And is there any curriculums that ASMBS offers and so forth that you know about?
So my number one thing I always tell everyone is, ask your rep. So ask anybody track down anyone from Boston Scientific. They have the most courses going on at the moment because, they kind of rejuvenated the field. Full disclosure, I get paid for Boston for teaching. But I generally mean that, right? So we started working with them years ago when the scope was still pretty much in development. When I was at Stony Brook years ago, we were one of the first in the country to use it, and it's really just taken off. And they've done a really great job of setting up courses where if you ask them and you're really interested in doing it, they'll probably just set up a course at your hospital. They'll bring in a model, they'll train you, and you kind of go from there. If you go to any societies, I know SAGES absolutely does them. ACS does them. I think we're having some conversations about with FASMBS to do some of these courses as well, especially in the bariatric realm with all the new, SADI and duty and switch really kind of taking hold. We got to teach people. So that's probably my best advice is just track someone from Boston. They'll be able to direct you where to go. And usually what we do is we come in, we'll bring all the models, we'll kind of go over all this stuff again with you, and then we're going to get you to practice. The models, in my honest opinion, are really, really, really close to what you're going to experience in real life. Just kind of the movements and how things feel. So that's the best thing to do. And if you're a resident or fellow right now, or certainly if you're a resident, find someone in your hospital who wants to be a champion of this, another attending. And it's kind of interesting because, when I was at Stony Brook, I was the first one to do this, but then within about 6 months to a year, all of us were doing it. So it kind of easily propagates. And I mean this, I really mean this, is that if you could take out a gallbladder and you could do some basic endoscopy, you have all the skills to do this. This is nothing new. This is not anything fancy. You're literally just putting a scope in a hole. We do it all the time, right? We do endoscopy all the time. It's just literally just doing a couple of them, getting comfortable, and that's about it. So just ask around, reach out to the organizations. I think Boston Scientific Rep is probably the best way to go. They'll direct you where the next courses are taking place.
So just to add to that, I just want to add to the fellows, right? Like just because you haven't trained with something and you haven't learned that during your fellowship doesn't mean that you can't do that. I didn't know how to do robotics before I started my practice. I didn't know how to do these procedures. But there are a lot of training programs out there. And just like Dr. Docimo said, for these, it's a spyglass. Is it Apollo or is it Boston Scientific? I think they're merged together, but it's called the spyglass, and Boston Scientific reps do that.
Yeah, Boston Scientific acquired Apollo, so they have all like such and stuff. This device was developed specifically with Boston Scientific, so they saw a need for it and developed it. So yeah.
Right. And they will actually come to your hospital, and you just have to find a group of surgeons who want to do this. And like Dr. Docimo said, a champion, and then it'll just take off. And every time I have had these, the rep will come, no matter what time of the day it is, they will be there just to get you comfortable with this. Like, you know what you need to do. It's not rocket science, you need to take a stone out, but then using the devices is where the reps can help you.
Absolutely. Yeah. And I think, most important too is like when you do learn this, teach as many people as you can. Train residents, teach individuals, teach other people how to do it. Our goal is definitely not to take over ERCP or to minimize it. I mean, ERCP is such an important procedure, but there's just such a huge need. And we just, we're hurting patients when we're not treating them early on in the process. Keeping them in the hospital for days on end is just it's not good for the patient.
100%. Yeah. One question, maybe controversial for you. So if we don't have spyglass, is there anything else that you can use? And I've heard things. I mean, I know there are surgeons who use ureteroscopy, ureteroscope, yeah.
So,
yeah.
There's some other scopes that are coming out on the market. There's one company out of China which we were able to we've used. I've used it like once in a lab setting. Very similar makeup. So there's a couple of other scopes that are coming down the pipeline in development. Historically, a lot of people have used ureoscopes, etc. My caveat with that too is that it's just those aren't FDA approved devices, right? So God forbid something does go wrong, it's hard to justify why we're using an instrument that's not made, even though I'm not gonna lie, a lot endoscopy, half the time I'm doing stuff that's not FDA approved. So it's just the nature of what we do. So just be careful, that's all, just make sure the instruments that you're using are you have good visualization, good lighting, and you're fine, It's
Dr.
like,
Docimo, I just want to be respectful of your time. Do you have 5 more minutes, 10 more minutes? We just have so much interest that you have so many questions. Are you good?
yeah, we're good. We got 5 more minutes. Let's do it.
Okay. All right. The next question is, any advice if you're in private practice or otherwise don't have access to residents or fellows to help with these cases? Apparently, I did a few cases in the residency. They're really nice, but you always need someone skilled to help you.
So robotically, if you got someone who you trust, once they can actually just kind of feed the scope in. And if you're doing this robotically, like as I mentioned before, you have really total control over the device to feed it in. Once it's in the common bile duct, you can just go to the bedside and do the procedure itself. Laparoscopically, I have to agree with you. You got to have at least you have to have someone on the other side of the bed that can at least hold the anatomy for you. But the difference is that, what you could do, what we've done sometimes was we will hold the scope in the 5-port with my left hand, and you can actually reach over with the grasper and actually help feed it in. Really difficult to do. I don't recommend it, but I agree with you. It's like everything else in life. You got to have a really good, solid team. If you're trying to do a lap bypass and you have someone who's never done one before, it's just impossible. So yeah, in private practice, like just kind of find 1 or 2 individuals who are helping you out, and just really kind of train them up and get them up to speed as well. Like when you go and train and do this stuff, bring them along. That's sweet.
All right.
Is any questions that you wanted to ask?
Well, I know we're running short on time, so I have more just of a comment, which is first and foremost to thank Dr. Docimo on a very, very interesting talk. You can't see my paper, but I've been scribbling down notes, just trying to capture and absorb as much as I can. But I think I speak for a lot of us young surgeons here that I think we all have an inherent interest in learning to do this technique just because we know the impact it can have, especially on our patients. And so I know a lot of us listening in today are probably going to be very motivated to seek out these skills and incorporate that in our future practice.
Well, I appreciate that. And you kind of set the foundation for us with your talk too as well, because you see there's going to be such a huge need going forward that I think especially if you're going to be doing bariatric surgery, you should be doing this. It's our responsibility to really kind of take care of these patients. And kind of interesting in our hospital now, when a patient with a history of a bypass comes in with a CVD cone, if they got a gallbladder, we get called. It doesn't even go to GI. It will go directly to metrics.
That's awesome.
Trust me, they don't want to do a transgastric ESP just as much as
they don't.
So
GI hates doing transgastric.
They're gonna get a nice pat on the back. Yeah, they're not gonna hold it against you. So yeah, and that's a nice way to get your foot in the door too. You're gonna say, hey, listen, these are tough patients. I do this procedure. When you get these cases, I'm gonna try to tackle them first and try to avoid transgastric ERCP and all this other stuff. So
great. And are there any other questions that we have in the chat box?
Nothing too exciting. Have you ever had to use a lip tube? Words are hard.
Yes. So we have one that's it's one that just basically kind of puts off a little energy. It's an energy device, right? So all you're doing is you literally you put it on top of the stone and you zap it. It can be a little time consuming because literally you're just breaking away tiny little pieces of the stone. But once that's done, you just go and you push all the debris down into the duodenum. That's it. So it's actually kind of fun.
Perfect. There's another question about dilators. What brand or specification of balloon dilators do you use?
I have Boston Scientific. They have balloon dilators. Boston has created I'm sorry, I keep saying, I'm just telling you what I use. Yeah. But Boston Scientific has an entire portfolio of devices now that go along with the scope. So they have wires, they have all the balloons. That's just the type that we use. But there's balloons from everywhere. You can get Cook, you get all different types. That's just what I happen to use in practice.
Perfect. Dr. Docimo, we can keep asking you questions. I have so many more questions, but we respect your time and thank you. This was awesome. I've heard this lecture before, and I knew the residents and fellows were going to benefit so much from this. So Thank you for coming and enlightening us, and we look forward to having you back again soon.
Absolutely. I appreciate all you guys, and thank you so much for the invites. It's my honestly honor to be here. So thank you. I appreciate it.
Absolutely. Happy Thanksgiving, guys.
Yes.
Thank you. Happy Thanksgiving.